We will be presenting a lateral parietal occipital arteriovenous malformation. This is a 37-year-old female who presented to a primary care physician with headaches and dizziness. She had no evidence of any visual complaints. A physical exam revealed no evidence of any neurological deficits, visual fields were full, and sensation was normal. The MRI demonstrated multiple draining veins, indicating a right parietal superficial arteriovenous malformation. The coronal and sagittal MRI demonstrate that the AVM is on the parietal occipital sulcus. Angiography revealed multiple feeders from the posterior cerebral artery. Based on the size and lack of deep venous drainage, the AVM can be classified as a Spetzler-Martin grade 2 AVM. As with any AVM, one must carefully inspect for feeding artery aneurysms. In this case, there was a clear P2 aneurysm measuring 5 mm seen on the coronal cuts. This AVM can be characterized as a lateral parietal occipital AVM. Given the risk of rupture of 2% per year by the Aruba study and the feeding artery aneurysm rupture rate of 1% per year, surgery is the mainstay of treatment for these AVMs. When comparing treatment modalities, life expectancy analysis may be helpful. As shown here, surgery offers the highest life expectancy for unruptured AVMs at this age group. Because the arterial feeders are superficial, preoperative embolization may not be necessary. We will review the systematic surgical approach to these AVMs. AVM surgery can be divided into 6 main segments: exposure, subarachnoid dissection, identification of draining veins, ligation of arterial supply, peel and deep dissection, and obliteration of the draining vein, and ultimately resection of the AVM. For these AVMs, surgical exposure must be wide to identify the entire nidus. A parietal craniotomy with 4 boreholes may achieve adequate exposure for a lateral parietal occipital AVM. As you can see, surgical exposure will identify the borders of the AVM on the subarachnoid surface. Once adequate exposure is achieved, subarachnoid dissection can begin. The dissection may begin at the parietal occipital sulcus. This helps free tethered veins from the arachnoid and expose the AVM margins circumferentially. Opening the arachnoid also permits for CSF release and relaxation. Once exposed, the draining veins must be recognized and preserved. This is the fundamental tenet of any AVM surgery. Vessels larger than 4 mm should be considered a vein until proven otherwise. For this lateral parietal occipital AVM, veins drain into the posterior and anterior parietal veins as well as the postcentral veins. As the dissection continues and the draining veins are identified, arterial supply is then identified and ligated. Larger vessels can be taken with aneurysm clips, while smaller vessels can be sacrificed with bipolar cautery. Feeding arteries for these AVMs may arise from branches off the parietal occipital artery and from the P4 segment of the PCA. When there is a question of whether a vessel is a vein or an artery, a temporary clip can be applied. If pulsations dampen away from the AVM, it is a vein and must be preserved. After these first 4 steps, peel dissection ensues to ensure that you are able to tackle the arterial front. In the case of parietal occipital AVMs, the dissection should begin at the anterior or inferior front and allow you to march along the AVM so that you can take the arterial feeders sequentially. This dissection is taken to a depth of 1.5 to 2 centimeters. As the march continues across the AVM, deeper dissection can be performed until the last feeding artery is taken. Deep ependymal vessels may be very friable and may need special attention to obtain hemostasis. The dissection is continued until all margins are free from any attachments. This signifies nearly the end of the AVM resection. The draining vein should turn from purple to blue. Once the bed is inspected for any additional attachments, the draining vein may be taken. At times, aneurysm clips or wet clips are necessary to secure the draining vein. Once the AVM is removed, hemostasis is essential at the end of the case. Post-operatively, strict blood pressure control is important. Raising the blood pressure by 15 mm of mercury and inspecting the bed for surgical bleeding may help confirm resection of the AVM. Intraoperative angiograms are also helpful to confirm that there is no residual nidus in questionable cases. Post-operative angiogram demonstrated obliteration of the AVM. The left PCA aneurysm on subsequent angiograms diminished in size, related to decreased flow through the aneurysm. This case reveals many important points. Draining veins should be preserved until the end of the case. Feeding artery aneurysms have a relatively high risk of rupture, estimated at 1% per year. Once the AVM is removed, however, these feeding artery aneurysms may decrease in size due to flow-related changes. No treatment is indicated if the aneurysm recedes after AVM resection. Post-operative follow-up angiograms are indicated for this reason. Thank you.